Good morning, good afternoon, and good evening to wherever you are connecting to this webinar, and welcome. Thank you for joining us to today's webinar, Skin NTDs Beyond the Tropics, from migration to climate change on skin health. My name is Rie Yotsu, and I'm the chair of the NNN Skin Cross-Cutting Group. The webinar is organized by the NNN Skin Cross-Cutting Group as a part of the World Health Assembly Resolution Implementation Task Force of the International League of Dermatological Societies. Skin-related neglected tropical diseases, or Skin NTDs, as many of us are more use this term nowadays, have traditionally been associated with specific geographic regions, often confined to the tropics and subtropics and the impoverished communities. However, the reality is changing. Patterns of human migration, urbanization, and global climate change are reshaping where these diseases emerge, how they present clinically, and who is affected. Today's discussion invites us to look beyond old boundaries, both geographic and conceptual. Skin NTDs are increasingly encountered in non-endemic and high-income settings, challenging clinicians, public health systems, and policymakers. At the same time, climate change is altering ecosystems, vectors, and exposure risks, making skin health an important lens through which we can understand broader global health transitions. With this emerging trend, we selected this topic for this year's webinar to celebrate the World NTD Day. We hope that today's webinar will provide you with new perspectives and insights, and we thank you for being part of this important conversation. And with that, I would like to invite Dr. Niraj Parajuri, who's the Vice Chair, who will walk you through our agenda today. Dr. Niraj?
Thank you so much, Dr. Lee. Good morning, good evening, and good afternoon, wherever you are in the world. And thank you for joining us for this NTD Day Celebration Webinar 2026. This webinar, we try to focus on the changing scenarios of skin NTD beyond the traditional concept of what we believe it is from the tropics and the subtropics and in the poor and the impoverished communities. The psychological impact it has on patients, families, and the societies, and even worse, with the problem of migration and climate change on its epidemiology and the presentation. Furthermore, we'll highlight on the importance of World Health Assembly resolution on skin diseases as the global public health priority in tackling all of these issues in a more holistic way. For this evening, we have a privilege to have an excellent panel of speakers who bring clinical, epidemiological, and policy perspective to this timely topic. Before we start the webinar, I would just like to mention that the webinar is divided in two sections and each followed by a Q&A section. Because of the limitation of time, we would request you to put forth your questions in the chat box, and then hopefully request the speakers as well to reply it at the chat box if we run out of time. With the further ado, I would like to start this program and invite our first speaker, Dr. Rie Yutsu. Dr. Yutsu is a dermatologist and a public health expert in skin NTDs. She has worked a lot in borreliosis ulcers and leprosy, both in endemic and non-endemic areas. She has also prepared the WHO document on NTD framework. She has played a key role in the clinical research in borreliosis ulcers in Japan. So with that, I would like to again invite Dr. Rie to present her topic for this webinar. Thank you.
Yes, so thank you, Niraj, for that introduction. And so I will kick off this webinar with talking to you about body ulcer in Japan. And on the slide is showing the global distribution of body ulcers, and the most cases are concentrated in this West and Central Africa. But in Southern Australia and also in Japan, these are the two countries which are located in the non-tropical regions that we report cases to WHO. We have cases, and also we report to WHO about these cases. And in Japan, we have 4 seasons with winter very cold, but nowadays with the global climate change, my background today is Mount Fuji, but we are experiencing less snow. So, yes, so the first talk will be from Japan. This slide I prepared for those of you who are not very aware of the disease body ulcer. This is photos from West Africa, mainly from Cote d'Ivoire, where I mainly implement my research projects. And this is a disease caused by a bacteria called Mycobacterium ulcerans. And so it's a mycobacterial disease, so it's a sister disease to tuberculosis and leprosy. It affects the skin and the subcutaneous tissue and destroys these organs, destroy the skin, manifesting into these deep ulcerations. The disease is known to be, this is a river in Ghana where many cases, called the dense river, where many cases are concentrated. So it is known that there's some contact with the environment, often close to the water bodies where the patient contracts the disease from some water source. But the specific transmission route is not yet known. And it manifests this with disfigurement and deformities, hence classified as one of the NTDs. And in Japan, we've had our first case diagnosed in 1980 from the Shinshu prefecture. And it is this strain that we find in Japan is different from what we find in Africa, and specifically called as Mycobacterium ulcerans subspecies Shinshu ense, taking where the first case was found. And we've been doing some epidemiological studies on these cases, as these publications show. Currently, a total of 89 cases have been reported to date. After the first case in 1980, there has been the blank years because nobody knew that the disease existed in Japan. But since 2004, when the Leprosy Research Center actively tried to detect the case, every year we've been having at least one case since then. We don't have concentrated area for the distribution of our body ulcer cases. It's more sporadic, as shown on the map. It's more dependent on whether or not the physicians know the disease. So for Okayama and Shiga prefectures, these cases, they have the most cases in Japan, but these cases have been reported by the same physician or the same institute. So this also shows how the awareness is related to the diagnosis. On the right-hand side is showing the referral pathway of how the patients are diagnosed, and the Leprosy Research Center has been acting as a referral center for diagnosis, doing PCR, and also providing advice for case management. These are some of the cases that we've been diagnosing in Japan. The cases in Africa, most of the cases affect the exposed areas of the body, on the face or on the limbs. The difference, I will say, is that because the darker skin tones, the redness are more apparent on our cases in the Japanese cases as compared to the cases in Africa. And what is interesting about this body ulcer is that the pathogenesis is not dependent on how the growth of the bacteria, but it is more this lipid toxin which is produced by the bacteria called mycolactin, which causes the necrosis of the deep skin tissue that presents with this necrosis underneath the skin, and that presents with this redness. But if you see this case, it's the same extent, the disease is the same extent, but you cannot really appreciate that necrotic tissue damage. This is showing the characteristic of body ulcer cases and reflecting the older population in Japan. The median age of the cases are around 56, and we have older cases as compared to African countries where they have more of cases in children. And also one thing to note is that even though with the high healthcare level in Japan, because physicians are not aware of the disease, often there is delay in diagnosis. Therefore, only 16% were cured with antibiotics alone, and many needed to undergo surgery and also cured with WHARI. This is a case in 2022, a case looked after by Dr. Sakakibara in Toyama Prefecture. And when the patient came to the clinic, first access, the lesion was with a nodule with a central ulceration. But by the time when she was diagnosed, the start of treatment, she developed this edematous lesions, so the subcutaneous necrosis extended, so she got severe, and she needed to undergo surgical debridement and skin grafting. This patient resided in the rice, next to her house there was the rice field, and also in Japan we don't know the exact transmission route, but often the patient is associated with this proximity to some water bodies, usually stagnant water bodies like the rice field or artificial dams. So this patient, she underwent 2 surgical debridement and then skin grafting and cured, but with these deformities. She is scheduled for more plastic surgeon surgeries to have these deformities fixed. So her treatment is still ongoing. And the slide is showing one of our research work that we did with the Swiss DPH find and the DDTD with this rapid diagnostic kit, which to detect the mycolactin. But for now, this is only for research use. So the take-home message is that even in non-tropical country like Japan, we experience skin NTDs like body ulcer. And even in Japan, with high level of healthcare, patients with body ulcer may be faced with delayed diagnosis because of limited awareness, leading to deformities and disfigurements. Transmission route is still unknown, and we are doing research studies to know more epidemiology, transmission, and also for better case management. We are open to provide support for case identification and confirmation to other countries, especially in Asia, which we believe small countries should be affected by body ulcer. And on the slide is showing a case report from India that that they've diagnosed woolly ulcer histopathologically. So unfortunately, the PCR was negative in this case, so we cannot confirm it, but the histopathology is highly likely to be woolly ulcer. And this case report was very interesting that it was just 2 weeks before I was going to Kolkata, India. So I was fortunate to meet the dermatologist who diagnosed the case, Dr. Tsubrada, and we exchanged our knowledge. And also that's why the sample was shipped to the Leprosy Research Center in Japan. So no reporting does not mean no disease. And so if you see some similar condition that looks like woolly ulcer, please have woolly ulcer as a differential diagnosis. And support is there. Like the Leprosy Research Center in Japan are happy to help. Also, there's now the Skin NTD LabNet by WHO, who's also happy to help to diagnose the case. And lastly, this is the publication we had recently, a review paper in Nature on woolly ulcer. So for those of you who are interested in the disease, please take a look. And that's all from me. Thank you so much.
Thank you so much, Dr. Lee. It was very enlightening presentation, particularly with borreliosis in more affluent and non-tropical country. Thank you so much for shedding light on it. So moving forward, then I would like to call upon our next speaker, Dr. Guadalupe Strada Chavez. As we all know that implantation mycosis are more common in the rural and poor communities and occur secondary to trauma. But Dr. Guadalupe will be talking on implantation mycosis in the urban communities in Mexico. Dr. Guadalupe is a dermatologist and a member of Community Dermatology Mexico and a professor of dermatology at the Faculty of Medicine in the University Autónoma de Guerrero, Mexico. The floor is yours, Dr. Guadalupe.
Thank you very much, Doctor. Just give me a minute to share, because I am still struggling a little bit with this, but I hope it works good. Is it possible to see it now?
Yes.
That's good, right? Perfect.
Yes.
So thank you again for the opportunity to share with you today our experience in Mexico. Thank you to the organizers for the invitation. Today we'll be talking implantation mycosis in urban Mexico. We are part of Community Dermatology, and I have no conflicts of interest for this presentation. As a general introduction, well, to know that implantation mycosis, as you well know, is this group of skin diseases caused by fungi that are introduced through the skin or mucosa, and it can be either by an injury or direct contact. It used to be known as subcutaneous mycosis, but now, because as it's well known that it does not only affect subcutaneous tissue, so now the name has changed to implantation mycosis, which can have an origin sapronotic or zoonotic, and it includes a wide group of diseases as porotrichosis, chromoblastomycosis, eumycetoma, lobomycosis, and entomophthalmomycosis. As it addresses today, it's from very tropical and subtropical areas. And fortunately, now with the World Health Assembly resolution regarding the skin diseases as a public health priority, it's very important that all this group of NTDs, as is endemic implantation mycosis, that we are well aware, because they affect mostly low-income population and people that are in conditions of underserved population. We are a wide group of developing countries that have the big presence of this implantation mycosis. And well, always skin diseases have to be identified as a global public health priority. Why? Because they have a very severe morbidity. And unfortunately, these are the group of diseases that have a very severe sequela that causes disability in this group of patients. and they will be affected in many ways, but also in their family income, as if they cannot work, they will have no resources to keep having a certain quality of life. They have always economical repercussions in many ways, and it also includes the way that these patients have the need of long-term treatment. And it's also needed to be, we need to be aware that these patients in their communities, they can be affected with a certain amount of social stigma that affects also their quality of life at their communities. But regarding urban Mexico, we need to be we need to know that in cities, there are some, especially in Mexico, there are certain rural habits that are maintained in urban settings. As it's not rare that people like to keep cooking with wood as fuel for tortilla griddles or pots, and even in a like well-established house, because they say food tastes better with wood as fuel. People, it's not rare that they keep their sandals outdoors, or they can be barefoot. Houses are frequently used with thorn fruit trees. They can be also ornamental plants, but as you can see, even though they are very beautiful, they also can be very aggressive with lots of thorns, and can be very can be a risk for it. And some houses, they like to have their adobe walls, which is a mud, clay, and hay paste, because it keeps the temperature fresh in some of the inside houses. And so they also like it as a decorative or traditional purposes. And that's why we like to mention that every city has its own rural heaven. So it's we need to consider that part also of idiosyncrasy related to the traditions of certain houses. Regarding specifically about sporotrichosis as an implantation mycosis, well, as you know, it has a clinical aspect of fixed and lymphangitic. And even though in those rural is the most frequent, but also urban, it can have, Brazil has a lot of epidemic outbreaks related to house cats. And here in Mexico, especially in the urban Mexico, it's considered as an occupational hazard, mostly in gardeners, handcraft packers, because they still use a lot of little threads to make handcrafts. And it can be affecting hands and the face. It's one of the most frequent implantation mycosis. And we don't have as many reports related to cats, but we have some ones now reported recently. And about eumycetoma, we also see it a lot in urban settings, not as many as we see them in rural environments, of course, but the construction workers are at higher risk because they use wooden formwork to constructions to build the houses and the the floors, the walls, etc. But they can be injured very easily with splinters. And after they start with their clinical aspect, they can be very easily misdiagnosed as osteosarcoma, as this patient was. And I received him in the Institute of Cancer, because they all thought that it was an osteosarcoma. Unfortunately, these patients, they usually delay their diagnosis, they have insufficient treatments. And of course, as we all know, it has a long-term treatment necessary, and it's a long-term disease. And this happens a lot, especially with cryptic mycetomas. Whereas in this other case, that it's a mycetoma of Mericopsis romeroi, also known as Parenocetum romeroi, and this patient had inoculated after a flooding of cages. He liked to keep roosters. In Mexico, a lot of people still like to have the practice of fighting roosters, and they invest a lot as it's used for bets. And so this patient had his roosters, and during the Hurricane John, the precipitation was over 900 millimeters and 37 inches. So the mud was up to the waist. And so he wanted to save his roosters. So the hay and the mud, it causes several micro injuries, which cause a multifocal mycetoma on the legs. This is something that I would like to mention because climate change have affect a lot, and we have our share of hurricanes in Acapulco. The first one was Otis, and after one was Hurricane John, with a lot of mud and a lot of destruction. One of the most severe was in 2023 Hurricane Otis, which struck Acapulco in a very severe way. It was one of the most severe hurricanes that we ever had in our country, and the wind speed was over 330 kilometers, which is over 200 miles per hour, and is equivalent to a Category 5 tornado. But this usually lasts for 20 minutes the most. And this one lasted for 40 hours. So this caused a lot of damage. This caused a lot of extreme condition. And afterwards, there were proliferation of diseases, not only as, like the general diseases, but also dengue, gastrointestinal dehydration. And of course, health services were completely blocked after a while. And I generated this images just to see like the size of how big this hurricane was. And this is important and relevant regarding implantation mycosis, because these patients will be exposed during the reconstruction and the clearance of certain areas after the hurricane's effect. That's why implantation mycosis and climate change need to be addressed as well, as there will be infrastructure with a lot of destruction of it, flooding, and suspension of basic services as energy, water, gas, food. And of course, as there are a lot of landslides, that it affects a way that at the end, people end up even looting and affecting it in so many ways. But the implantation mycosis and the comparison between the rural and the urban is that in the rural areas, people are usually peasants or farmers. And this will affect a wide range of age groups. They can start even children because they get involved in the field work very early ages. As we mentioned, the wood for cooking can be in both areas. The wood fences or the thorn fences for cattle, it is also a group of, of injuries that is a risk. The patients usually at the rural areas, they use sandals as they are very cheap, and some of them, they use it as traditional, and they are affected in the lower limbs. Sporotrichosis has a rain season relation, and this all causes that patients they are very distant areas. They will delay their diagnosis, and they don't get transport because of unsafety. Rather than in the urban environments that are mostly of gardeners or construction male adults, they still use wood for cooking in female. But it's also related to hobbies and house animals. Upper limbs are more affected, but it also will be continued to see related to climate events. And it's not rare that they are misdiagnosed, as we saw with other infections or oncological diseases. I would like to conclude that urban and rural Mexico, of course, we have in both vulnerable population, that there are still facts that affect like economic, politics, education, and poverty that will all have health repercussions. These patients, they always delay their medical attention, and they are usually misdiagnosed because there is still insufficient specialized care. And let's consider that in Mexico, there is one dermatologist for every 53,000 inhabitants. And in our city is one for every 43,000, and even 1 to 126 in the whole state of Guerrero. So that's why it's a big relevance, and that we know that there's a lack of services. In urban and peri-urban areas, even though they are less exposed to soil and vegetation, they still need to be early detected and treated. And there is still a lack of specialized care. We need to address the lack of resources for implantation mycosis, which of course now with the goal to eliminate the NTDs globally, I think that's one of our goals around the world. And with the resolution, that's also something that we are so hopeful that will improve at the end the service delivery and efficiency, of course, and with now the strategic framework for skin-related NTDs. Migration will affect also because there are people traveling from rural to urban areas, so there need to be awareness of implantation mycosis, and especially also in general medicine. And unfortunately, climate change will continue to create meteorological events. So that's why we need to also consider the consequences related to these emergent diseases. And thank you again to all, and have a good day.
Thank you so much, Dr. Guadalupe, and highlighting again the urban population with implantation mycosis and its impact with the migration as well as climate change. So I would still request the participants, if you have any questions, please put it up in the chat box. Next up, I would like to introduce my dear colleague, Dr. Ramesh Sharma, who is a young, energetic dermatologist from Nepal and who has spent more than 10 years taking care of patients of the neglected ones, particularly leprosy. He has extensive experience on dealing with patients with leprosy who have shared their stories of joy and sorrow and beyond with him. He would be sharing some of these stories with us today. He's currently working as an assistant professor at Pokhara University in Nepal. Dr. Ramesh, please present your cases with us.
Thank you, Dr. Neeraj, and all the organizers. It's my privilege to be presenting here on this very important day of...
Dr. Ramesh, can you put it in the slideshow mode?
I'm sorry, what happened with this? Sorry. Is it working?
No, go to the bottom and then there's a comments, and next to the comments, the slideshow. Put it. Can you just press it?
Okay.
Yeah.
Is it working?
Just a moment. Yes, now it's working.
Thank you.
Continue.
Okay. So my presentation today would be hidden scars, stories of skin NTDs and its psychological impact on patients. So I'd like to start with the first story. Doc, I'll commit suicide if. So it's a story of a 50-year-old female who was diagnosed with leprosy and under treatment for type 2 reactions. She had a history of recurrent ENLs, which are very painful and debilitating, as we all know how ENLs take course. She needed multiple admissions at the hospital, usually for thalidomide. So that is our protocol. We admit patients for thalidomide treatment. So we can see the nodules on her face and the pigmentation due to clofazimine. Actually, this story is not of this patient, but the story is of her daughter, a young daughter of 20 years age, who had been witnessing all the troubles of her mother. The journey of this patient from hospital to home and back to the hospital, time and again, the daughter had been the witness of all these troubles. So the daughter came with a hypopigmented and hypostatic patch on face. So we took a brief history, we examined the patient, and after all this and a brief discussion, her first comment was, "Doctor, if you are saying to me that I have to take that medicine my mom has been taking, which is clofazimine, and I'm going to get pigmented and I'm going to commit suicide." So in this plain statement, single statement, we can find the reflection of the trauma the patient has been going on and the family has been suffering for these last many years. So with this single statement, I think it's a very powerful statement and words that reflect how difficult the journey has been. So another story is of a painful swollen foot and cross-border travel for treatment. As discussed by our previous speaker, Dr. Vada Lepe, that there's so many cases where diagnosis has been late and treatment has been very difficult. So a story of a 40-year-old male who is a farmer by occupation, long-standing, non-healing, multiple plaques, multiple sinuses, and swelling of the foot. He visited many hospitals, underwent many investigations, including X-rays, MRIs, and biopsies, sometimes, many a times, not going to any conclusion. So it was the first presentation where the foot is swollen and there are multiple sinuses. Actually, when I received this patient, he already had undergone few surgeries in season and then training of these grades. So the diagnostic dilemma has always been an issue because of unavailability of specific diagnosing tools or maybe lack of expertise. So he was given multiple antibiotics, antifungals, anti-tubercular therapy, but only partial remission ever. Multiple surgeries even for the removal of grails. And after long duration, I came into contact with a doctor in India at AIIMS Jodhpur, Rajasthan, who has started using intralesional amphotericin B injection once a month. So this patient was sent to that hospital where he went for 8 months, every month for a visit. So we can see it's more than 1,573 kilometers from his home to the hospital in Jodhpur. And obviously, it's not easy to travel across the border from Nepal to that far in India every month. The finance, the time he has to spend, and everything, that's quite a bit of trouble. So a few days back, I called the patient to send some pictures of how he has been doing. So there's a marked improvement, and he's also quite satisfied with these improvements. So these are the pictures sent by the patient himself to me. So third story is of tingling sensations and a patch, a tale of two generations. So story of a 30-year female from a remote western village of Nepal who had some tingling and paresthesia of extremities. It was very disturbing. She sought advice at various centers and was given multiple drugs which were not quite effective. She was even started clonazepam because of her troublesome symptoms. She had been referred from local hospitals to regional hospitals to big hospitals in Kathmandu and up to New Delhi. So in this journey of many, many years, she had started developing multiple painful subcutaneous nodules and erythematous plaques in between. So she had developed ENLs, which were very difficult to diagnose for many, many physicians and clinicians. She had even underwent electrical stimulation therapy at a hospital where there was a temporary relief, and she was called up for a follow-up next month. But again, in between that time, I found her and diagnosed. The total duration of all these events was about 6 years. And in between this, interestingly, her 5-year-old boy developed multiple ringworm-like plaques on her cheeks, legs, and forearms. So when the son presented with this, they went to a different doctor, and a dermatologist clinically diagnosed the boy as leprosy. And before meeting him, he had also been treated in the line of fungal infection. So finally, he was referred to a Green Pastures hospital where I worked, and it's a leprosy center. And we diagnosed the mother and the son with leprosy and started the treatment later. So we can imagine the financial burden of more than 600,000 rupees that I happened to calculate in those 6 years. The psychological burden of carrying an undiagnosed disease, visiting all those hospitals, and having to have a tranquilizer for an otherwise treatable condition. So the fourth story is of a disfiguring plaque, a friend for life, a 44-year male farmer who developed a slow-growing plaque. It was asymptomatic, so the patient didn't tend to be concerned about the lesion. So until it became too big to ignore. So when it became too big, he came to the hospital. So it is very difficult to treat the patient given the large plaque. So another similar story of a 70-year male with varicose plaques for more than 20 years duration took anti-tubercular therapy from other centers without improvement. On biopsy, we can see these beautiful medullary bodies, but their life was not beautiful, as we can see those beautiful lesions in the picture. So when the patients present late with larger lesions, it's very difficult to treat because the response to therapy is very poor. So confirming the diagnosis and treating them with the available drugs is again still a challenge, and patients usually have to live with these persistent unresolved plaques forever. So the implications of these stories would be that NTDs are neglected from many aspects, not only from the policy level, but also from the patient's level. Usually it affects the poor and marginalized, the voiceless people. They're neglected by the patients themselves who seek treatment very late. Maybe there are many different factors like finances, like cultural issues, and many things. Even they're neglected by the clinicians. Maybe neglected is not the right word, but there's a very highly diminishing expertise to diagnose these conditions. Even when the patients reach hospital in time, it's very difficult to diagnose because we are losing expertise in diagnosing these cases. And even if we diagnose the cases, there are various tools for diagnosis and treatment. Financial burden with these chronic diseases, they are not often talked about. The psychological issues associated are usually neglected because we don't go beyond the clinical or the morphological things. So interestingly, we see many patients who have been smiling despite the hidden scars behind. Stigma is staggeringly high, we know. not only the stigma from outside, but self-stigma is also quite concerning. So road ahead, how we can help is maybe we can become the voice of the voiceless, more and more advocacy, and emotions over statistics. So if we count the number of the patients, they might not be very high. So unless we start looking into the burden of the disease in terms of emotions or the sufferings of the patients, and only count them on the basis of numbers, we are not going to achieve more. So we should be looking at individual patients and the emotions, their psychological burden, and their sufferings rather than dwelling only on data. So leprosy work could be an example in which there are self-help groups who are helping each other, the patients, the groups, though leprosy is sometimes a controversial, I call it a highly political disease, and integration of skin entities with each other is very important in my opinion, as we have been doing and we have been discussing for many, many years now for strategic and financial planning both. So I found a proverb which says, teeth can only bite when clenched together. Maybe this webinar, this discussion today would be another milestone in clenching togetherness of these teeth so that we can make a fruitful bite. So greetings from Pokhara, the land of the mountains. So it was a very nice sky today morning after yesterday's rainfall. Thank you very much for this active listening.
Thank you so much, Dr. Ramesh, for highlighting the stigma and the hidden scars of patients with neglected tropical diseases, not just leprosy. Because when we talk about leprosy, we tend to miss the other skin-neglected tropical diseases. And I find it very interesting when you said that it was not being neglected by the community, but the doctors as well, as we are lacking the expertise of doctors handling these cases as well. So thank you for sharing your expertise and your insights in patients and their problems with us. So let's move ahead with our next presenter. Our next presenter is another expert in, again, skin-neglected tropical diseases. For the last decade or so, antifungal resistant dermatophytes are on the rise, particularly Trichophyton indoteinae. And more frequently, it's been reported from the South Asian regions. But however, it has become a global issue. Our next speaker, Dr. Rudiger, is highly qualified to address this issue from an European perspective. Dr. Rudiger, a dermatologist with a particular interest in tropical and travel medicine, and currently working at the University Medical Center, Rostock, and the current chair of Tropical Dermatology Taskforce of European Academy of Dermatology and Venereology. Dr. Rudiger, I would like to hand over to you for the presentation.
Thank you very much for this kind introduction. I hope you can hear me and you can see my screen.
Yes, perfectly.
Oh, wonderful. Yeah. So thank you very much for this opportunity to present a bit on the resistant dermatophytes in Europe and the situation we face in here with the subtitle, should it be a concern? And I think I do my best to answer that question. I would like to show an exemplary case that we had here and actually are still having here in our university clinic in Rostock. In the dermatology department. It was a 40-year-old patient developing for the last 7 months a tinea starting in the groins, and with the first mycologic diagnostic result of Trichophyton interdigitale. Of course, everyone will be a bit skeptic seeing this, and everybody knows where it will go. Under local cycloperox, bifenazole, and clotrimazole, there occurred just further spreading of the lesions, and then terbinafine was induced, and it was insufficient. It's another picture of that same patient. So, and just to see, just to show how widespread the disease was, I just present you these pictures here, and of course, we started our own diagnostics, and it came up as we thought. The result was a Trichophyton mentogrophitis genotype 8, the so-called Trichophyton indoteinae, and it was shown that to be terbinafine resistant, which is the problem with this fungus. As you all know, it was itraconazole sensitive in our diagnostics. Interestingly, the patient did not report any travels outside of Germany, He had no contact persons suspicious of transferring the fungus to him, and he was the only one affected in the family. So we are still struggling with the reason why he got it. So is speculation of, is it an autochthonous case or not? And but just to see what is going on with this fungus, here's an overview of all the cases that had been reported in the last time all over the world. And you see not only those areas where it was first detected, like in the near Middle Eastern area, but also many countries in Europe have reported this type of fungus. And Professor Ninov has just published recently a new re-evaluation after 5 years of the state of Trichophyton indotinea, genotype 8 Metagrophytes in Germany. And I had the honor to participate in the publication, and he could report that in the last 10 years we have had intense increase of cases, at least on the diagnostic levels in the lab. You see, in 2016 there were in the lab just was one case report. Now we have 73. Among those he was investigating, we had like around 62 of these turbinafine being turbinafine resistant, and even 6% itraconazole resistant, and double resistancy was shown in 2.7% of cases. So that is really a matter of concern. And in comparison with other countries, actually, they show similar results. There was a report from UK with an increase from 2 to 90 cases in more or less the same time with turbinafine resistancy in around 74% of cases. So very similar results. Reports from Belgium, reports from Switzerland, reports from Greece. I couldn't add all the reports that show that. But that shows that it's not a Central European thing, it's a general European thing. Of course, it differs from country to country. So the question was about resistant dermatophytes, so I also looked a bit into other types, and what you see is that there are some rare resistancy cases for Trichophyton rubrum, and outside of Europe also for Trichophyton tonsurans, but they don't really play a role yet. So it is in Europe, it's a story about Trichophyton metagrophytes genotype 8. Interestingly, these three types of Trichophyton, they with turbinafine resistancy, they show very similar or even the same types of mutations. And what is the problem? Of course, the problem is the treatment, and what treatment options do we have? Okay, itraconazole is usually a thing that is recommended, or super itraconazole, super bioavailability itraconazole, and different in a lower dosage. And for all these cases, it's a long-term treatment that is recommended. And but what do we do in cases with itraconazole resistancy too? So then there's voriconazole and posaconazole, which actually are more like for deep fungal infections reserved substances. Other substances like fluconazole and griseofulvine usually do not really work. It is typically recommended to combine the treatment with topical antifungal agents like cyclopirox or azoles, like also even the local voriconazole or luliconazole, which is not available in Europe. There is discussion about using some shedding agents that act by keratolysis, by removing the fungus-laden scales of the skin by salicylic acid. Even there's reports about isotretinoin that shows that actually people all over the world treating that are really struggling with getting rid of that. So coming back to our case, we started as recommended itraconazole and combined it with cyclopirox, and there was an improvement, but no real clearance. Probably in this case, the reason of non-clearance might be, at least in parts, an inconsequent treatment that had different reasons. Some recommendations were misunderstood, etc. But what developed in this case was a secondary itraconazole resistancy. So we had a patient with double resistance against terbinafine and itraconazole. So we shifted to voriconazole, improvement but no healing. Then we just tried for a short time fluconazole. We had a stable disease, and we combined it with salicylic acid, and then we checked again, and the patient was itraconazole sensitive again. And so we started super itraconazole and combined with cycloperoxone salicylic acid. You see also we struggle, and we are still struggling. The patient is still under treatment now for 3 years. And that is a quite recent picture of the same patient, and that is the only lesion left. So I think we are not too bad with our treatment. It somehow works, but it's not absolutely insufficient in total. The length of treatment that we have to undergo, the patient actually has to undergo. So the rise of it, is it a matter of concern? Yes, it is. One must really say. And the reasons for that, why it is a problem. We have an increased frequency that doesn't show any sign of finishing. So we will face a further increase. There's even an occurrence of double resistant strains with resistance against terbinafine and itraconazole. It is a discussion about, so it's not the only case that we have, that we might even have autochthonous cases in Europe already, as it shows human-to-human transmission. So it would make sense when you have enough cases, you will see that. A long-term treatment is necessary, and there's a lack of alternatives in treatment. And some of these treatments that are used in other parts of the world are not available in Europe. So that is just for finishing, and I thank you very much for the attention, and I'm happy about questions that might come to this topic.
Thank you so much, Dr. Rodiger. Yes, coming from the South Asia, I know the problem of registered dermatitis is quite huge, particularly in Nepal as well. And then from a presentation, we noticed that it's us, we create the problem, and it's us, the problem is more to handle as well. So thank you so much for sharing your insights on this important topic, which has not been limited itself to a certain reason, and it has gone beyond the boundaries to the Europe and the US, just to mention a few. We have now been to the end of the first segment, and if there are any questions in the chat box, then we would go with the questions. Otherwise, taking the consideration of the time, I think we should move forward because we are a bit late on time. Just a moment. All right. So, would everyone stop me?
No, I'm just trying to encourage participants to put the questions in the question and answer. So we want to make this more interactive, so please do that. Thank you.
Thank you so much, Dr. for the encouragement, and I hope we have a lot of participants, and I hope they would be encouraged to get more questions for our panelists and the speakers as well. Now to move to another section where we'll be tackling on the migration, issue of migration, climate change, and the World Health Assembly resolution on skin disease, and how this will help Skin NTD as a whole. So for the next session, I would like to invite Dr. Valeska Padavese. Dr. Valeska need no introduction. She is a dermatologist with special interest in migrant health, and she would be sharing the impact of migration on skin NTDs. Global data of 2024 has shown that there are more than 42 million documented refugees globally. Beyond the refugee crisis, global travel through land, air, and sea has made the world a smaller place for us, but not just us, even for the pathogens as well. It has become a smaller world, as we recently know with the pandemic. So Dr. Valeska will be talking on the impact of migration, particularly on skin NTD. She is a special advisor on migrant health and sexual infection for International Foundation for Dermatology and ILDS, and a member of European Sexual Medicine Network Board. Dr. Valeska, over to you for your presentation. Thank you so much.
Thank you for the kind introduction. I try to. Can you see my screen? It's okay? Can I start?
Yes, please.
Fantastic. Thanks and to everyone for attending this very interesting webinar. So I'm going to talk about my favorite topic, migration, and in combination with Skin NTDs to Europe. I'm also the lead of the Genitourinary Clinic in Malta, so I'm a dermatologist and venereologist, apart from being the special advisor for the ILDS and the chair of the Migrant Health Working Group. So I have to look a bit into the data of migrants and migration to Europe. In 2023, I mean, in recent year, Europe reporting an increase of migration to the European countries in relation to political conflict, economic crisis, and also climate change. And this has introduced an increased risk also of neglected tropical disease within the migrants and displaced population. These figures are from 2023. I found them in the Eurostat website. And we see the number of migrants to our countries in 2023 have risen to over 4.3 million coming from countries outside Europe. So these are only the number, these numbers refer only to migrants from third countries, not intra-European migration. And this number don't include the Ukrainian displaced people and refugees that move to the other European countries because of the conflict. And while NTDs typically impact tropical regions, their presence among migrants in Europe is a growing challenge because we don't have much data about, so statistical data about the prevalence of skin NTDs in migrants to our countries. And because also there is a limited awareness and education among dermatologists on how to recognize, suspect, and diagnose these conditions. And I want to highlight that Malta, the country where I work and live, is the first in this list because we have the higher number of migrants from outside Europe, from per country per 1,000 inhabitants. So over 76 migrants, immigrants, international immigrants per 1,000 inhabitants in the country. This table shows some of the most common skin NTDs, and I look a bit into the literature, in the scientific literature, and I found that really few studies attempting to define the prevalence of neglected tropical diseases among migrants living in Europe. One of these is reported here. It is a research, a review of literature, a meta-analysis and review of the literature of 148 studies run by the colleagues from WHARI University, over 228,000 migrants in Europe. And spondyloidiasis and schistosomiasis were the most common neglected tropical disease. When I went to read the article and I look on the evidence of from systematic review about skin NTDs, I found really scanty data. And the most common skin NTDs imported to Europe by mass migration were referring mainly to leprosy, cutaneous leishmaniasis, and scabies. Therefore, I will focus mainly this presentation on these three skin NTDs. This table and the map, again, are extracted from the article of the colleagues from the University of Bari. And we see that also this research, the meta-analysis, was done mainly from countries of the Central and Western Europe and not from the Eastern European countries. So data are not complete. So there are still a lot of missing information. Going to talk about scabies, I don't need to talk about the epidemiology. You know that migrants coming to European countries and suffering from scabies They imported this infectious disease in relation to their living condition during their transit to our countries, or because they often share overcrowded spaces in camps or in terms of labor migration, they share apartments. So this skin infestation is very easily transmitted from one to the other. We estimate, the WHO estimated 5 up to 50% of children in resource-poor area are affected by scabies. And scabies also cause a significant health burden, around 15% among forcibly displaced population. And in this photo, there is the typical clinical presentation in a child with the lesions on the soul. Public health intervention, including WASH program, improved surveillance, are very important to reduce transmission and improve health in displacement settings. I want to show this case. This is just one of the many cases that we see in both migrants. A very young Eritrean migrant presenting on arrival in Malta with multiple genital ulceration. You can see the lesions on the penis. These are covered by crust. They were all super infected, and you can imagine the bacterial super infection only looking at the lymphadenopathy, the groin lymphadenopathy. The migrants was referred to the sexual health clinic where I work because they were suspecting a sexually transmitted infection, not scabies. Obviously, the migrant was complaining, I mean, the sexual history. There were a lot of linguistic barriers, but we managed to get the sexual history and also the more information about the clinical presentation. And he was complaining of generalized nocturnal itching, very typical of scabies, since he was detained in Libya. So we see many, many migrants from Libya detention arriving to our countries with this clinical presentation. And looking better at his hands, we saw the typical sign of scabies, of superinfected scabies. So the diagnosis, the clinical diagnosis was easily performed, and the treatment, antibiotic and topical permetry treatment was started. I found this interesting paper because there is a lot of talk, a lot of discussion about resistant scabies imported by migrants to our countries. And this recently published paper in the DMJ 2026 in January, so this month, showed the effectiveness of permethrin, topical permethrin cream, 5% versus oral ivermectin. And a superiority of the statistical superiority of the 5% permethrin cream over ivermectin. This was a multi-center, assessor-blinded cluster randomized clinical trial run by our colleague, and Olivier Costinot is a worldwide expert of scabies, was the leading author of this paper. So most of the time we talk about resistant scabies, but in reality, probably we refer to a pseudo-resistant scabies with an increase of no response to topical treatment because the medication is not properly applied, or because of environment conditions, so the poor hygiene and the lack of intervention to improve, WASH intervention to improve the living condition of migrants in our country. Another important imported skin NTD is leprosy. I found some few data about leprosy in Europe, but this important review of 17 case reports or case series reported 280 migrant patients diagnosed with leprosy in Europe between 2009 and 2018. And another retrospective study established in Italy in the same period described around 55 cases in refugee migrants with a diagnosis of leprosy. You can imagine the country of origin were mainly Africa, Asia, and South and Central Asia. So I also decided to report some cases that we recently described and diagnosed here in Malta. In the last 3 years or 4 years, we had 3 new cases of leprosy. Malta, as you saw before, has a very high percentage of the population being migrants from third countries, and we import mainly labor migration. This is a case of a 29-year-old man from the Philippines, presenting within a 4-year history of enlarging erythematous spot over the outer aspect of the right arm, you can see in the photo here, and a 6-month history of erythematous brown nodular lesions on the face, trunk, and lips. He reported numbness and reduced sweating over the macular lesion in this area, but all the other lesions were asymptomatic. So he moved to Malta from the Philippines 20 months previously, and a skin biopsy was performed and supported the clinical suspicion of borderline lepromatous leprosy. And triple therapy started with improvement of the clinical picture. This case was published a few years ago. And this is a case that is still, it has been submitted for publication, and I thank the colleagues from the dermatology department for providing the photo and the clinical description of this case. It's a 24-year-old male from Nepal, residing in Malta for the last 2 years, with no recent international travel and no past medical history of note. He presented with these multiple papules on the upper arms, earlobes, and trunk. This is also a dermatoscopic images of one of the papular lesions. And the number of this lesion was increasing and spreading on the ear and also on the face. You can see the description, this nodule non-tender and hypopigmented, distributed on the ear, cheeks, forearms, and legs, and the palms and sole and the trunk, whereas also the genital region were also spread. Also in this case, the suspicion of lepromatous leprosy was confirmed by a skin biopsy. So what are the warning signs or red flags to learn how to suspect leprosy? We saw the skin changes, mainly pale or reddish or copper colored patches, typically numb to touch, with less of pain, but and also less of sweating on the macular lesion. And in more advanced form, there are the nerve damage, the most characteristic sign leading to loss of sensation, nerve enlargement, so the thickening of the nerve, the median, the ulnar. So these graphic, this picture show the area where we should palpate, and we should learn to palpate the nerves to exclude the neurological involvement. And the patient can also complain of muscle weakness and paralysis, mainly in hands, feet, causing conditions like closed hands or drop feet, but again, even in the most advanced cases. So in migrants to our country, as you can see, you have seen from the photo, we can suspect leprosy from really mild clinical presentation. So we really need to think about it. I report here some clinical picture of leprosy in dark skin in migrants that I've met in Italy, so tuberculous leprosy with these hypopigmented patches, so maybe easier to spot in a darker skin person, but also differential diagnosis with other skin conditions related to dryness, atopic dermatitis, pityriasis alba, eczema. So we have always to test the sensitivity on these patches. And the case of lepromatous leprosy in a camp in Tanzania. Other important skin NTDs related to migration, another important skin NTDs is the cutaneous leishmaniasis. This is mainly imported to Europe from the Middle East, so countries with Syrian refugees or Afghani or Pakistani refugees. There is a transmission risk also locally in our countries in relation particular to the presence of the sandfly vector in the Mediterranean area. So Italy, Malta, Spain, Greece, these areas, these countries are more prone to see outbreak also among the local population. As you know, the clinical presentation can vary between ulcer, papules, or nodule, and cases are frequently misdiagnosed due to lack of familiarity with this disease among European healthcare providers. And the management is different based on the type of leishmaniasis species identified by PCR from skin biopsy or mainly from the histopathology and the skin biopsy. Obviously, cutaneous leishmaniasis represents a public health concern because the rise in cases necessitate better surveillance system and in particular training of doctors in our countries. I report here some clinical picture I've seen in migrants from Syria, so Syrian refugees. You see multiple lesions in the photo-exposed area, not only upper arms, but also the lip in this Syrian refugee, very young Syrian refugees, and a girl that I've seen in Al-Zatari camp with an important scar post cutaneous leishmaniasis. This photo of indirect skin, these are all migrants and refugees I've seen between Italy and Malta. And we see small lesion. I worked many years in Ethiopia, and I was used to see extreme, extensive clinical presentation of cutaneous leishmaniasis. What I've seen in migrants in Europe are just a small nodule or papule, and that respond quite well to the topical treatment with cryotherapy or to the use of antimonials, pentavalent antimonials. These are two clinical cases. Whereas these two patients were seen, I've seen them here in Malta. This was the one on the left was a Libyan young boy with these lesions on the face, leaving a permanent scar after treatment. Whereas on the right, we see a patient, a female patient, young, coming from South America with this lesion that a biopsy and confirm cutaneous leishmaniasis. The climate change has further contributed to the expansion of sand flies habitats, obviously increasing cutaneous leishmaniasis transmission in unaffected areas. And again, I want to stress the importance of training healthcare providers in non-endemic regions to avoid underreporting and misdiagnosis of cutaneous leishmaniasis with delayed treatment and morbidity. And finally, I know the colleagues talk about dermatophytosis, but it's an important topic I work on in the last years together with the Taskforce of the ADB on antifungal resistance. We have seen an increase of dermatophytosis, fungal infection, superficial fungal infection, mainly caused by trichophyton indocine and resistant to treatment. We ran a study in Europe showing an emerging antifungal resistance or treatment failure. We started a study that is going to be, we just submitted to the ADB about the genotyping and the study of antifungal resistance of the species we identified among many European countries partner of a multi-center study. These are some clinical photos that I've seen at the genitourinary clinic. We see a lot of infection in the genital area. And this raises suspicion also of a sexually transmitted component of this fungal infection. So the transmission is skin-to-skin contact in my patients. And this is a recent publication that we have submitted to the SED and just published. Many of our patients, the patient I've seen recently at the clinic, come from Southeast Asia, from Bangladesh. Erythematous and itchy rash, multiple lesions, but also patients from Africa. So probably local transmission is also, in this case, is a component. So local transmission is spread tinea genitalis in the genital area. Again, patient from Bangladesh, male and female, in the perianal area due to skin-to-skin contact. So in India, Bangladeshi patient on the right and an Indian patient on the left. And a patient from Bangladesh, again, with a very spread and resistant Trichophyton mentagrophytes. The variance was indocine. The indocine was detected through genotyping. We have to stress the fact that our local laboratory are not trained and they don't usually have the test to determine the genetic type of Trichophyton and so also to address, to help the clinician to address the correct therapy. So in conclusion, I want to stress that screening for NTDs upon arrival in Europe is a significant impact in preventing the chronicity and the spread and the complication of skin NTDs, offering clinical benefits to patients and reducing healthcare costs associated with many secondary effects. But migrants are often neglected, like the disease that we are trying to target and to increase the diagnosis of. They face a significant barrier and challenge to address dermatological services because usually they are entitled only to emergency care. They have linguistic obstacles and bureaucratic impediments. They have issue with communicating with healthcare providers and restricted by language barrier, and access to non-urgent care is usually impeded by financial constraint and lack of insurance. Furthermore, the restrictive policies frequently result in the exclusion of migrants from healthcare services, necessitating the use of emergency service only, and this limited access can lead to delayed diagnosis of skin NTD. So we really need to work to improve access of migrants to care. And I thank you for this for the time, and I'm ready to take some questions in the chat.
Thank you so much, Dr. Valeska. Thank you so much, Dr. Valeska, for your insight. It's quite interesting to know that the pathogens do not know of any boundaries, any borders. And then what we see in the tropics are all over in European part of the continent. And it's very certainly concerning that you are seeing infective spectrum of leprosy in your part of the world. So I think the theme of this meeting is well aligned to what we are trying to do globally with the World Health Assembly resolution. So as we are running short of time, there are a few questions for Dr. Rudiger on the Q&A section. Please kindly address it. And for all the speakers, please kindly check the Q&A once in a while to see if there are any questions addressed to you and reply them over the Q&A section. Now, I would like to have the privilege of welcoming Dr. Eva Parker. She's well known in the climate change scenario. She's assistant professor at the Center for Biomedical Ethics and Society, Vanderbilt University Medical Center. As we all know, climate change is already reshaping where infections and skin disease occur. Climate change is no longer a future threat. It's already influencing the disease pattern and the place where we live in. As we heard from Dr. Valeska in a previous presentation, the pathogens are there everywhere globally without caring about the borders. Now, more so, how are they doing in the scenario of this global warming? So to highlight on the issue of global warming and the climate change and its impact on Skin NTD, I would like to have the privilege of welcoming Dr. Eva and share her knowledge on this important subject. Over to you, Dr. Eva.
Thank you so much. Can you confirm that you can see my slides?
Yes, please go ahead.
Thank you so much for inviting me to talk about this critically important topic. Because of greenhouse gas emissions from fossil fuels, the Earth is now 1.3 degrees Celsius warmer than it was in the 1880s. The result is the growing threat of extreme weather events, droughts, wildfires, melting polar ice, and sea level rise. Human activity is also increasing UV, radiation, and air pollution. And while specific climate impacts vary by geography, every nation is affected. Importantly, however, vulnerable and marginalized populations experience disproportionate impacts from climate events. The complex interactions of climate change affect multiple scales, disciplines, systems, and societal levels, resulting in wide-ranging consequences, including a global health crisis with overburdening of health systems and exacerbation of existing disparities, massive economic repercussions, failure of infrastructure, food and water insecurity, poverty, mass migration, conflict, and intergenerational inequities such that future generations will be disproportionately affected. The result is a funnel effect on health impacts from the pressures applied by climate change, such that our overconsumption results in ecological harm, which drives and creates the hazards that are the proximate causes that harm human health. Politics, poverty, structural racism, conflict, and migration further amplify these effects. The result is that climate change is a threat multiplier for health, equity, and health systems. And these interlinkages uniquely impact skin NTDs. We must also consider this funnel effect of climate change on NTDs through the lens of One Health, understanding the critical interface between us, animals, and the environment. We know urbanization, habitat destruction, and climate change alter ecological niches and increasingly bring humans and animals into contact, which heightens the risk of outbreaks of zoonotic and vector-borne diseases. Moreover, in the context of widespread antimicrobial use, higher temperatures along with environmental pollutants and microplastics additionally contribute to rising rates of antimicrobial resistance. In thinking about these effects, we know that key ecological, immunological, epidemiological, and social cofactors contribute to the incidence of skin NTDs. And not only does climate change impact infectious disease burden and widen existing gaps in health disparities globally, climate-related pressures increasingly threaten and disrupt NTD surveillance, reporting, and treatment programs. So let's contextualize this further. facilitated by poverty, unsafe wash, food insecurity, poorly constructed housing, and limited health services, NTDs affect more than 1 billion people globally. And the increasing pressures of climate change amplify the global health, social, and economic burden of these diseases. Specifically, there are disproportionate and compounding health, economic, and equity impacts from heat, extreme weather events, and pollution in the global south. For example, more than 780 million people globally are currently exposed to the combined risk of poverty and serious flooding, mostly in developing countries. Additionally, the global south will experience outsized increases in heat-related mortality. Skin NTDs in particular are highly climate sensitive and impacted by heat, precipitation, drought, and extreme weather events, resulting in multifactorial and intersecting effects. For example, precipitation and flooding provide breeding habitats for mosquitoes, and warming expands the geographic range of insects and enhances replication of pathogens within vectors. Additionally, many fungal pathogens now display thermotolerance to heat, and higher temperatures are associated with greater antimicrobial resistance. Flooding is also associated with a greater risk of infections, and extreme weather events perturb soil and frequently cause trauma, increasing the risk of inoculation of soil and debris and inoculation mycoses. Importantly, these events also damage infrastructure, electrical grids, transportation, and telecommunications, leading to disruption in surveillance and MDA programs and access to digital healthcare. Nutritional status is a critical risk factor for skin NTDs. Climate change will amplify food insecurity and worsen malnutrition for vulnerable populations because extremes in temperature and precipitation influence the timing, quantity, and quality of crop yields. Additionally, increased atmospheric carbon dioxide levels increase plant biomass, thus lowering the nutritional density of food crops. Agricultural impacts also trigger population migration, which may further affect NTD incidence and control. Increased rates of NTDs are observed in climate refugees due to overcrowding, poor nutrition, and lack of water, sanitation, and hygiene. NTDs also reinforce barriers such as discrimination and poverty, which are then amplified by the socioeconomic, health, and psychological pressures of climate change. But just like with disease, climate forces also influence health systems in complex and multifactorial ways and subject the healthcare sector to broad pressures from climate change. Damage to infrastructure from billion-dollar climate disasters is increasing worldwide. Extreme weather events hinder care access and delivery of our dermatologic care. They disrupt global supply chains, they threaten institutional financial security. And so collectively, climate change is anticipated to dramatically increase disease burden and healthcare demands. Consequently, health systems will be increasingly threatened in the future, which may contribute to neglected tropical diseases becoming more neglected. Exploring vulnerability is key to understanding climate impacts on skin NTDs. Climate vulnerability is influenced by physiology, agency, geography, sociopolitical and socioeconomic factors, and access to resources and care. We know women, children, and the elderly bear a significant portion of the global health burden. And outdoor workers, marginalized groups, those with physical disabilities, and people living in poverty are also at increased risk. Psychosocial impacts, physical disabilities, stigmatization, and mental health disease are critical long-term sequelae for those with NTDs, contributing to downstream socioeconomic and human rights implications, making those with NTDs highly vulnerable to the health, equity, and economic impacts of climate change. And while the wealthiest 10% of the world's population is responsible for 50% of global greenhouse gas emissions, a massive climate gap exists such that climate impacts are disproportionately shouldered by low and middle income countries. The Global Climate Risk Index highlights how climate change affects the most economically disadvantaged people, with each of these nations listed here producing less than 1% of total global greenhouse gas emissions, yet being the most vulnerable to climate impacts. Also, economies in low and middle income countries have a disproportionate dependence on sectors most affected by climate change, such as agriculture. And climate-related agricultural productivity losses of more than 30% have already been observed since the 1960s, compounding poverty and food insecurity. Climate change will worsen this in the future. And these disparities have created a divide where the economic gap between the world's richest and the world's poorest countries is now 25% larger today because of global warming. And this trend is set to continue and result in income losses of more than 80% for many tropical and subtropical nations by 2100. Importantly, the economic forces imposed by climate change are expected to have critical knock-on impacts on NTD incidence and control. Because of climate change, tens of millions of people will be pushed into poverty, which is a major cause of migration. By 2050, the displacement of up to 1 billion people is predicted as a result of climate events. And in particular, climate events exacerbate existing social vulnerability and political instability and contribute to complex humanitarian crises. Climate-induced population displacement and migration alters and amplifies patterns of infectious diseases. An example is the Syrian civil war, and Valeska alluded to this, where recrudescence of leash was seen in Syria in association with this conflict, which had stemmed ultimately from climate impacts. But beyond the direct impacts, populations at greatest NTD risk experience the effects of climate change first and have the least resources for adaptation and resiliency. Consequently, the pressures applied by climate change amplify these multidimensional disparities and accentuate health impacts. This vicious cycle underscores that the critical interlinkages between climate change, health equity, and care delivery must be addressed in capacity building and NTD control strategies. Impacts from climate change act as threat multipliers, amplifying disease burden and disparities, increasing medical demand, damaging critical infrastructure, triggering population migration, and destabilizing nations economically and politically. Any of which could potentially derail progress towards achieving NTD control. Yet these specific climate-related barriers to successful integration and control of NTDs are not addressed in the WHO strategic framework. All 20 integrated interventions for skin NTD control are highly susceptible to climate change, directly or indirectly, and thus prioritization of these climate impacts must be addressed in our frameworks if NTD control is to be successful. And in summary, in the context of the WHO resolution with skin diseases now recognized as a global public health priority, addressing the complexity of climate impacts on skin health, especially for those with NTDs, is essential. To achieve integrated prevention and control of NTDs, we must engage stakeholders and collaborate multi-sectorally to develop context-specific, cross-cutting solutions that consistently include considerations for climate impacts and strategies for climate mitigation and adaptation. Funding a climate and health research agenda must be prioritized to fill knowledge gaps and identify the barriers and opportunities for integrated control in the face of climate change. And we must champion climate education, and our advocacy and policies have to support resiliency and environmental justice in vulnerable and marginalized populations. And so I thank you so much for your time. Please feel free to email me with questions or put them in the chat. Thank you.
Thank you so much, Dr. Eva. It's quite ironic that the migration, the climate change, all skin entity, they all affect the most vulnerable population of this world.
Yes.
And then it's interesting even to know where the vulnerability lies, there is still a hope. And for our next presentation, I would like to welcome my dear friend, Professor Dr. Wendy Megan, who will be highlighting on the studies and the publication that had come from the tropics and that had impacted the global policies and humanities. As we all know that Africa produces roughly 1% of world scientific research despite having an 80% population. And who better to talk on this than Professor Wendy, who is a vice chair of WHO NTD STAG team, as well as a vice chair for GLODEM, and International Alliance of Control of Scabies. Professor Wendy, please take and then take over for your presentation. Thank you so much.
Thank you, Niraj. You can hear me? Yes. Yeah. So my talk is going to be on, when we're talking about skin NTD, the most important gap we are having is especially the knowledge gap, the lack of evidence both on the prevalence or the burden, the diagnosis, and the management of those skin NTDs. So I'm going to take you through some of the evidence. Sorry. Slide. Okay. So, just I'm going to focus on the skin NTDs, but you know that in this the WHO list, we have now currently an updated around 21 NTDs. And from those 21 NTDs, around 18 of them either primarily or secondarily affects the skin. So the most common skin NTDs, especially focusing on Africa, are especially you can know that scabies, cutaneous leishmaniasis, leprosy, podoconiosis, and Brulis ulcer, mycetoma. And surprisingly, even though we know that these are prevalent or endemic in most of the African setting, their real burden is not known. So there is some reports from WHO, as you know, when we are thinking those skin NTDs and their evidence, and most of the evidence is generated from those what's being reported to WHO. But as you know, most countries actually they don't report or the report is misrepresented. So the burden of skin NTD in Africa in general, it's just it's known with a high burden, and those NTDs and skin NTDs especially, they are mostly in the rural community, affects the rural community and results in extreme high disability. Because of their stigma and exclusion, most of the patients actually, they don't even present to the health facilities. And some of the hidden cases we have seen recently in our study, actually those NOMA cases and so on, even though they have obviously disfiguring diseases, they have been living with the disease for a decade without visiting health facilities because of the stigma, associated stigma with it. No, this is just one of the major evidence gap, and to resolve this issue, definitely the research matters. But the big issue in Africa is we are really, really underrepresented. Africa, despite having 90% of the global entities, it only have around 90% or 20% of the research are undergoing. So for this, we need some advocacy and we have to really work onto the elimination targets. So those health research in Africa, especially as we have said, there is what they call it a critical gap, 10 to 19 gap, with 90% of global investments addressing only 10% of the global health problems, largely ignoring the continent disease burden. And the key issue includes the lowest per capita research density, especially in Africa, and poor data infrastructure, limited funding, and the no-to-do gap in implementing research finding to the policy. And I think those three figures talk about more or less what's going on, what's the big gap in Africa, the current state of health research on especially disease of poverty and neglected infectious diseases. As you can see, one of the things is in recent research led by EDSTP or funded by the EDSTP has shown that more than 50% of African policymakers understand they have a poor understanding about clinical research capacity. And from those who has been asked, the most important barriers are just the first thing is the lack of funding, which is accompanying more than two-thirds of the case, and then lack of policymaker understanding, lack of human resource, and lack of infrastructures. So when we see, even in Africa, you can see that there is really a big variation between those countries like South Africa, which have a state-of-the-art research facilities, and countries like Ethiopia, they have countries with existing research infrastructure, which benefits capacity strengthening, and some countries even they don't have a basic infrastructures. So the big issue when it comes to research in NTDs, especially in disease of the poverty and in Africa, is those researches, even though the diseases are endemic, most of the publications are going out supported by the foreign aid, Western universities, and even sometimes led by Western professors. So one of the lessons from this is actually in Africa, we need a local leadership for researchers, and especially in doing some context-relevant researches. And there is a need for south-to-south regional networking. And the other most important thing is especially between the researchers and the policymakers. Most of the research papers which are being published, especially in our experience, they ended up either they can be published, but they ended up in even not accessible for most African readers, and especially for policymakers. And the other thing is also, most of the time, those publications may not be understood by the policymakers. And so to sort out those things, one of the things from our experience is, especially when it comes to the Skin NTD, in Ethiopia, even though we know that just we say most of from the 21 NTDs, we report around 18 of the NTDs. But there is a limited mapping of most of the NTDs. And surprisingly, actually, even though in our daily clinical practice as a physician, we see a lot of skin NTDs, we don't see them even in the WHO map. This is one example, as you can see from the WHO map of mycetoma. You can see Ethiopia is one of the non-reporting countries, even though we share around 720 kilometer border with Sudan, with the highest burden of mycetoma in the world. Ethiopia was not reporting. So we thought that actually with this, the 2030 NTD roadmap, the most important thing we need to do is actually to know the burden of the skin NTDs. So we used this opportunity and we did some estimating the burden of mycetoma and other skin NTDs in the country. And this study, we involved Ethiopia is a country with 130 million population and with 1.3 million square kilometer. So we used 4 regions and screened around. We trained the health extension workers or the primary healthcare workers to screen specific skin NTDs, especially mycetoma, which is the primary objective, scabies and leprosy and podoconiosis, lymphatic filariasis, and cutaneous leishmaniasis. And so we screened around 100,000 population, and this study has been concluded just last August. And from this, the health extension worker has identified or suspected case of 140 mycetoma cases and above 1,000 other skin NTDs and ovary-related skin diseases. From these, some of the most common skin NTDs.
Dr. Wendy, I just want to remind you, you have just gone over time. We are running late, so I want you to please kindly wrap it up if it's possible.
So these are just some of the skin NTDs from the field we have found. and or the health extension worker has screened. And the most important thing from this study is just to know that yes, at least we put the country in the map of the WHO mycetoma, and you can see that just the lesson learned behind this is training focal health extension workers or primary health care workers can help us actually in integrating screening and reducing undiagnosed case of the community with the skin NTDs. I think, thank you, that's all. Thanks.
Thank you so much, Dr. Wendy. To proceed further, as we're running late on time, I would like to introduce our next speaker, who doesn't need any introduction, a person with a vision and who is passionate about bringing the stream of skin health for the world a reality. And with her strong will and her advocacy, the skin disease as a global public health priority, WHO resolution has come into life. It's my privilege to welcome Dr. Claire Fuller, who is Beyond Clinic, is serving on various organizations as a board of directors of ILDS, the chair for International Foundation for Dermatology, and co-founder for Glowderm. Over to you, Dr. Claire, to speak on the WHO resolution and how it impacts the skin entity.
Thank you very much, and I'll do my best to try and catch up with time. So thank you very much, Neeraj, for the introduction. It's lovely to be with you. I'm really excited. We've got more than 140, or have had 140 people joining us from more than 30 countries. That's just really exciting, all across the world. And I'm really impressed that Joseph Sangatio is still up. It's in the middle of the night in Fiji. So a special shout out for you. So what I am just going to try and do is to progress my slides, which are now having a tantrum, which I don't understand why. There's me trying to catch up. I am just going to try again and share because I'm just not being able to. There we go. So we all know the issues. We have training gaps, we have lack of diagnostic tools, and we have referral bottlenecks. And the World Health Assembly resolution has given us a mandate to address some of these things, and it's been very well crafted. What is a resolution? It's something that requests action. It's the highest level political commitment and fosters accountability and sets a precedent, as well as guiding national systems worldwide and influencing what the WHO decides to prioritize on too. So the key principles of the skin disease resolution are its implementation recommendations, and it's urging three groups or constituencies. It urges member states to do 10 things, and it urges the wider international community, such as us and those of us on the call, to support member states in addressing these 10 recommendations. And it encourages the WHO to develop and draft a global action plan, which will support countries that need some assistance in developing their own national plans of how to address these recommendations. So what are the opportunities for community skin health? We know, I've mentioned this, so I can just move on, the three constituencies. So how can the skin health community, how can we assist member states to deliver? Well, the International League of Dermatological Societies, which I'm representing in this talk, represents all the dermatology societies of the world. We have more than 200 member societies representing more than 215,000 dermatologists worldwide. But we are in official relations with the World Health Organization and provide technical dermatological information to and support to them, as they do not have a dermatology department. And so it's been a great pleasure to work with the WHO Secretariat and other parties to take this resolution forward and to be involved in supporting the implementation plan. I'm chair of the International Foundation for Dermatology, which is focusing on developing capacity and access to dermatological care in resource-limited settings. And this is why we've been so intimately involved with neglected tropical diseases and particularly skin NTDs. So the International League of Dermatological Societies, to kickstart the implementation process that has been detailed by the resolution, have launched the World Health Assembly Resolution Implementation Task Force, the WHARI Task Force, which is going to assist in getting things going, really, and incubating activities that will address what we need to achieve. And we're focusing our activities around these various pillars of focus, such as advocacy, resource mobilization, assisting countries develop their policies and their implementation plans. But most importantly, we've heard how important data is. If we're not measuring it, it's not happening. We need to have the data in order to demonstrate impact, but also to convince our political masters and policymakers that this is an issue. And absolutely critical is to involve those with lived experience, as well as civil societies and more extended communities than perhaps we've even used in the Skin NTD work up until now. It's absolutely crucial that we partner, and over the coming months, we will be needing to be very clear and accountable with what we're trying to deliver. Once the global action plan is developed over the next couple of years, we can use that to feed back impact to the World Health Assembly and document progress. We want to, at country level, support workforce training programs, telehealth implementation, and enhanced diagnostics and surveillance, as well as patient support and implementation. So we want to think very much about also partnering with as many other parties as we can, going outside necessarily just health, partnering in other areas where skin disease has an impact, and what's already happening to support wins for skin health globally. Well, the regional dermatology training centres, one in Moshi is the longest serving one for a resource limited setting, has achieved significant advances for supporting regional training across East Africa. And more recently, the Fijian Centre that is training Pacific dermatologists based in Fiji and is accelerating provision of dermatology's expertise in the region. World Skin Health Day is an initiative that we celebrate on the 8th of July and has, in 2025, had the most amazing participation across 76 countries with a real range of impacts and projects being trumpeted. The World Health Organization Skin NTD app is a diagnostic, an educational tool to support diagnoses, and includes common skin diseases as well as skin NTDs, and is developing an augmented intelligence support functionality. The WHO Essential Medicines list came out after the resolution was passed and has incorporated 3 dermatological products, sunscreens for those with albinism, with skin cancer, to prevent skin cancer in people with albinism in the tropics, and emollients in atopic dermatitis. We've talked about lack of data and how can we rapidly upskill this. If you'd like to link on this QR code, it will take you to an emerging study, Global Access to Skin and Health Observatory, led by Professor Esther Freeman. And this is generating the data. We already have data in from more than 81% of countries across the world, which is serving as a really useful baseline to start from, demonstrating questions and data on access to care. And it will lead on to a live a live platform which will be able to see real-time data. The Lancet Commission for the Transitioning Spectrum of Skin Disease has been launched, will complete over the next 2 years. This has happened since the resolution, and it's the first one in the 200 years of the Lancet. And we're developing a skin health training hub in order to support rapid access for frontline healthcare workers to train in basic dermatology. And we look forward to launching this officially, which will be open access and will have a credentialing facility across this. So now that skin diseases are considered a global public health priority, we're going to amplify advocacy to support implementation, support existing health initiatives and build new ones where we need to, and establish national accurate baseline and evaluation data. So I suggest you kind of hold these 10 areas in your minds as you start to service plan and so forth, as these are the 10 areas of implementation. And we are really excited that this will lead to change. So I'll stop there and thank you for the opportunity.
Thank you so much, Dr. Claire, and thank you so much for helping the global world with the Skin Health for All initiative. Next up, I would like to invite Dr. Kingsley from WHO NTD department, who has a similar dream of that of Dr. Fuller of having skin health for all. Dr. Kingsley will highlight the key process of WHO resolution implementation and need for a more multi-sectoral collaboration to make this dream of skin health for all a reality. Over to you, Dr. Kingsley.
Thank you very much for, I think Claire has made my work easier, so I will hope to make up for the time that we are short of. I hope you can see my slides.
Yes.
Okay.
Yeah.
All right. Okay. Thank you very much for the invitation. I will provide a brief update on where we are with the implementation of the resolution, particularly the development of the Global Action Plan. I will not go into this, but I'm sure that everyone is familiar. This is the resolution that Claire mentioned, and this is what we will have to be able to implement. One of them is the need for us to develop a global action plan, which we have started since October last year. The purpose is to help to coordinate efforts to elevate skin diseases as requested in the resolution and ensure equitable access to care. Issue of stigma, I think we have heard a lot about it. This will be addressed also in the Global Action Plan. What have we done? In October last year, we conducted a survey, open surveys, to gather information from everyone interested in contributing to the resolution and the development of the Global Action Plan. These are the results. I will not go into details, but out of that, this is just to show some of the areas that people wanted us to look at closely during the development of the Global Action Plan. So far, I think through some small group, we have reached consensus on draft vision for the Global Action Plan as well as the goal of it. This is just an abbreviated version of what we have or we will have in the main document. And then we have also agreed on 6 strategic objectives. I will not go into details. You will have the presentation to read through one by one, but these 6 areas will be the areas that we will elaborate to guide countries and partners in implementing the Global Action Plan that we hope to complete. In terms of timeline, as I mentioned, first the outline is completed. A team has been constituted. We will start working on the drafts in February, and hopefully by the end of March, we will have the first draft. In April, we will publish this on WHO website and disseminate the draft more widely for anyone to be able to make a contribution. And I invite everyone on this call and and others that when we come to the public consultation, try to review and make sure that you have also contributed to the content. And then hopefully in January 2027, this will be submitted to the WHO Executive Board. And we hope that at WHA 18, the Global Action Plan will be adopted. And from there, we will start with the implementation of it. But in parallel, it does not mean that until we develop the Global Action Plan, the other aspects of the resolution should wait. We can simultaneously begin to implement that. And this has already happened. Cote d'Ivoire had a workshop to look at how they will implement the resolution in their own context. I think the outcome was very interesting. There are other webinars, including this one that we are having, where the opportunity is used to also update everyone on the resolution, its implementation, and the global action plan. And so in conclusion, what I would like to say to everyone is that we have an opportunity with the resolution 78.15, and we should seize this opportunity to advance the work on skin diseases, give voices to those affected and their families. And we hope that the multi-stakeholder engagement and collaboration will lead to the change that we have all longed for, to highlight the importance of skin diseases. Turning the resolution to impact, I think there are a few areas we should remember. We need to champion skin health in national health agendas and make sure that they are reflected. Engage in the gap consultation, which I have mentioned. The need to strengthen the PAC and health workforce, capacity building, equity stigma issues, and then issue of data. I think this was alluded to, and the importance of also research and research gaps, and the need for mobilizing resources and strengthening partnerships. So I call on everyone to be on the lookout in April to be able to contribute to the draft global action plan, which we will share widely. Thank you very much for your attention.
Thank you so much, Dr. Kingsley. For all the participants, I think it's an exciting year ahead of us with the global action plan in place. I'd like to thank all the speakers for giving us your time, and all the participants as well for their questions and a very interactive session. To conclude this webinar, may I request Dr. Ri Yutsu to give her concluding remarks.
Thank you, Niraj, and thank you to all the speakers. And what we learned today is that climate change and human migration are no longer future concerns, that they are already reshaping the epidemiology of skin NTDs and other skin diseases across all regions. Skin health must be recognized as a shared global responsibility, required integrated people-centered approaches to ensure skin health for all, everywhere, as we also implement the skin disease resolution. We apologize that we did not have so much time to listen from all the participants, but we tried our best to answer the questions. And I put in the chat that we'll be having a survey sent out after this webinar. So if you have any questions, also comments, we'll have that free text also in that survey. So please use that opportunity to reach out to us. And so the time is coming, but I do see one raised hand. Do you want to have a word, Joseph? Or is it fine? So please use the survey, yes, to reach out to us. Okay. Please go ahead, Joseph, if you want to have a word. Okay, well, if not, we now collect the 2-hour time. So thank you again for all the speakers and for all the people who joined us. And I know that all of us are working towards for Skin NTDs and for the NTDs. And thank you for all the work that you are doing. And this has been a good celebration day for us all. And we look forward to continuing this conversation and the efforts to fight against Skin NTDs. So thank you, and see you again soon.